Bell Crab, and I'm absolutely thrilled that you could join us for the latest breast cancer trials Q&A. If you've attended one of these sessions before, you'll know that it's your opportunity to kind of speed date brilliant people in the field of research around breast cancer, talk to and hear from people who have been through a similar experience that you might be associated with just at the minute. If you're a newcomer to this session, please enjoy the opportunity to access information, hear people talk about some of the things that you or a loved one might be going through. This is the largest audience that we've ever had for a breast cancer trials Q&A. We've got around about 3,500 people registered for this afternoon's session, which I think is an indicator just how widespread interest there is in this pernicious question of side effects from breast cancer treatment. Now, a little bit about breast cancer trials. It's the largest independent oncology research group in Australia and New Zealand, and they've been conducting clinical trials research into the treatment and prevention of breast cancer since 1978, over which time, as you'll be aware, inordinately significant research progress has been made and continues to be made. Tonight we're going to be talking, as I said, about the side effects of breast cancer treatment and the latest in research. Our panel of experts are going to be answering as many of your questions that you've been sending in as possible on this topic. I do have a little bit of housekeeping to acquaint you with. First of all, before we get started, I'd like to acknowledge the traditional owners and custodians of the lands across Australia and New Zealand from wherever you're joining us this evening, afternoon, depending on time zone. And I'm coming to you from the Gadigal land of the Eora Nation, and on behalf of us all, I'd acknowledge elders past and present of wherever it is that you're hailing from today. Now, this is a fairly straightforward technological operation. There's a couple of interactive elements. So if you have your mouse or cursor and you move it over the screen to the bottom right-hand corner, you'll see three little dots. If you hover your mouse over those dots, you'll see some options. You can make a comment or send a question. If you click on ask a question, it's worth doing that because they'll all come through and be collated. If you have any technical difficulties, I always have technical difficulties, so I always listen to this bit. If it freezes or drops out, try refreshing your browser in the first instance. And if you're still having trouble, click info to find the link to access live chat support. But do not get in too much of a tiz because this whole session is being recorded. So in the unlikely event that you're unable to re-establish contact or you drop off the webcast, you'll be getting a link tomorrow in your inbox to be able to watch the whole event or indeed forward it to someone who you think might find it interesting. So welcome to you all, and I'm going to introduce our panel now. First of all, we have Katrina O'Doherty from the Breast Cancer Trials Consumer Advisory Panel. Now, Katrina was diagnosed with breast cancer very recently in 2022 at the age of 37. Katrina is one of the quiet heroes who, having gone through breast cancer, sticks around to help other people by advising breast cancer trials on the Consumer Advisory Panel. So thank you very much for being with us this evening, Katrina, and for sharing the benefits of your experience with all of us. Professor John Boyages, who was a radiation oncologist at the Icon Cancer Centre in Sydney Adventist Hospital. Just occurring to me as I introduce him that I asked him about pronunciation and I've just boldly mispronounced his name. It's Boyages. Fantastic name. Belinda Yeo, Dr. Belinda Yeo is a medical oncologist and the Deputy Director of Medical Oncology at Austin Health in Melbourne. And Dr. Keelan Byrne is a radiation oncologist from Melbourne at Peter Mac Cancer Centre and Icon Cancer Centres. So welcome everybody. Do not be put off by the fact that 3,500 people are listening in. This is, as I said, the biggest session we've ever had. It's tipped over diet and exercise. as the most popular topic ever. So I know that many of you watching tonight have experienced breast cancer, and others, friends and family, and want to learn more. Thank you so much for your questions and for tuning in. So just as a starter, I'm going to show you a little video just giving you an idea of the range of questions that Breast Cancer Trials has received on this topic. I always find that summary so moving. I think it's a really significant demonstration of where people are on their, one hates to use the term breast cancer journey, but it's unavoidable at this juncture. People are sometimes confused, not sure what they're undergoing, not sure what's normal, not sure what's abnormal. So the great thing about this session is the opportunity to dispel a bit of that confusion and to feel as well as though you're not alone. I'm going to, for that reason, I think, ask Katrina to start us off. Katrina, it's very good of you to come and talk to us so soon after all of this has happened to you. 2022 is not very long ago. Could you tell us the story of your experience of breast cancer and what happened when you were first diagnosed?
Sure, thanks, Annabelle. So yes, 2022, I was diagnosed after self-detecting a lump. So I was diagnosed with node-positive breast cancer. I was diagnosed on a Monday afternoon, and I was sitting in front of an oncologist that Thursday.
Wow. Okay. I don't know what the node thing means. Can you explain what that is?
Yep. So my cancer had spread to my lymph nodes.
Oh, I see. Right. And so Monday to Thursday, I'm thinking they would have been a couple of extremely turbulent days. Can you tell us what was going through your head, how you approached talking to your family and so on?
Yeah, I think from a family perspective, it was in consultation with my husband. We opted not to discuss it with our children until we had the full picture.
How old are your children, Katrina?
Now 12 and 14.
Oh, okay,
so
right.
I'm quite little. So I thought that was important for us to understand exactly what my treatment would look like, understanding it can be different for patients before we broached that conversation. So Thursday saw me sit in front of my team and presented out with the treatment plan, and then we went from there. From a feeling perspective, loss of control.
Yeah, and a feeling of, I guess, overwhelm and a deep and I imagine dizzying sense of just how much you didn't know, I guess, right? What did your treatment involve, and how quickly was that established?
Yes, so my treatment was very quickly established. So the Thursday in front of the oncologist, and the following Thursday I was sitting in a chemotherapy chair. So I had 16 rounds of chemotherapy, followed by 5 weeks of radiotherapy delivered daily. I initially was recommended a lumpectomy. However, given my age and the chance of reoccurrence, I suggested, or not suggested, I asked if I could undergo a double mastectomy, which my surgeon agreed to, which was followed by immediate reconstruction. I'm now in endocrine therapy, so 2.5 years into endocrine therapy, and that involves daily exemestane tablets, monthly Zoladex, and biannual Zometa infusions.
Okay, so that's a lot of things happening to your body over a pretty short period of time, Katrina. Are you able to just talk us through the various side effects that you experienced along that road?
Absolutely. I did think this would come up, so you'll have to bear with me. I had to go into the back of my cupboard into my cancer box that I've stored away safely, and pull out my wellness journal that I actually used quite a bit and still do on occasions. And for all the clinicians.
I'm just going to interrupt you. Like, what made you decide to do that, and how was it helpful for you?
It was a gift. So my sister gave this to me at the beginning of my journey. And as I was undergoing chemotherapy, it was during the COVID period. So unfortunately, I wasn't able to have anybody come into the suite with me. So having this journal was a great way to pass time and document some of the feelings and emotions along the way.
Oh, Katrina, look, two things. One, I'm very sorry that you had to have a cancer box at all, but I'm also very sorry that you had to undergo all of these confusing and isolating feelings when you were physically isolated as well. And I think recording what's happening to you is something that I'm sure would be therapeutic for a lot of people. I know I would find it therapeutic. So what can you, diving back into your cancer journal, tell us about what you were feeling and experiencing along that road?
Yeah, so from a side effect perspective, and apologies to the clinicians on today's call, but I will be using patient terminology because I think that's really important.
I don't think anybody's going to criticize you for that, Katrina. It'll probably make a lot more sense to everybody watching as well.
And I did think that too. So hot flashes, insomnia, shingles, nausea, diarrhea, anxiety, fissures, hair loss, nose scabs, joint pain, fatigue, styes in my eye, appetite loss, change to taste, back pain, mood swings, which my husband can absolutely validate, unfortunately, memory loss, GSM, and cording. From the radiotherapy perspective, dry, red, itchy, irritable skin would be some of the main sort of side effects.
And did you feel as though these were coming in any kind of recognizable pattern, or did you just feel like you were being pummeled by random things every day?
There were some that were pattern and still remain. I think it's that sort of consistency. They don't go away. However, they lessen, or you somewhat get used to the side effect, so you manage it better. Others have gone completely, thank goodness, and others, some more tolerable, others not so much.
How did you feel about the intensity of those side effects? Did you ever feel like, wow, I'm feeling so sick, this must be really working? I know some people feel that way. Did you feel able to ask for help? Did you feel that you had avenues for assistance?
I did. What I found with my side effects, I had a great team around me, and it was really important for me to be transparent around the side effects that I was experiencing. what I found when I did have those open conversations, there were options that would help mitigate or lessen the load of the side effects I was experiencing. And that was extremely helpful for me to be able to continue the treatment whilst being so ill.
I'm realizing I'm springing this question on you, Katrina. So if you can't think of anything off the top of your head, don't worry. But like sometimes in these sessions, people reveal the most unusual kind of hacks of ways to address side effects that you would never think about, you know, bags of peas and so on. Did you ever happen across anything that was a surprisingly helpful way to tackle a particularly pernicious side effect?
I didn't know. I was on the advice of the specialists. I think anything they suggested, I tried.
Yep. Okay. Well, there's normally friends and family who have strange ideas about things that you could try. I know that a lot of people experience that, but it sounds like you were pretty single-minded about listening to what sounds like an excellent team around you. Belinda, I'm going to come to you now just to broaden this out from your experience. Dr. Belinda Yeo, I'll remind you, is a medical oncologist and Deputy Director of Medical Oncology at Austin Health in Melbourne. Thank you for joining us, Belinda, and welcome. Does every patient going through breast cancer experience side effects from treatment? Are there any super lucky ones who don't? And what are the most common ones that you see?
I think if I'm honest, you're exactly right. You're super lucky if you don't. I think we expect to see side effects. I mean, for most people who are diagnosed, for example, with a breast cancer in the breast, you don't even feel it for most people. So anything we do, whether it be surgery or radiation, or you've just heard the plethora of drugs from Katrina that I'm responsible, or we're responsible for, they do give you side effects. And so, much of what I hope tonight is about is trying to explain how we try and balance those side effects with the benefit they can offer, as aside from the harm. But look, I think the vast majority of patients that we treat do experience some side effects. Yeah.
Common question that's come up repeatedly already is about side effects from hormone therapy in particular. Can you just give us an overview about this? What are the common side effects and what relief is available for patients?
So one of the reasons that's the most common thing, I guess, that's been asked, Annabelle, is because hormone receptor positive breast cancer is the one that is the most common. So it's driven by that hormone that is, endogenous. It's inside us all, more so in women than men, but it is in men as well. And hormone receptor positive breast cancer suggests that estrogen is driving that cancer. So our antidote to that, or our response to that, is that, well, if we can hide the estrogen from the cancer, or if we can stop it altogether, which is what Katrina has just described, then what we hope is if there are any cancer cells lurking around, they can't survive. So when we think of the side effects, we call it hormone treatment, but it's actually the opposite. It's like an anti-hormone. It's menopause plus, if you ask me. So hot flushes would by far be the most common thing, and they can be as annoying as, waking people up at night, drenching sweats, or, just hitting you in the middle of an office meeting in the day. Sleep can be disturbed for that reason as well, but also just our sleep-wake cycle can be interrupted, which is what also happens as you go through menopause. Unfortunately, weight gain is something that we do see quite commonly, and that can be really tricky because there's no sensible reason why. Patients say to me all the time, I'm doing exactly the same thing or more, and yet I can't shift the weight. And so that's something that many patients do struggle with. Joint pain, Katrina just mentioned, you're sore and stiff, and that's because estrogen, there's a bit of estrogen in our joints and it hangs onto that forever. So if you stop that being produced, then the joints tend to get stiff and sore. And the classic thing is when you get out of bed in the morning, when you get going, you kind of feel like the Tin Man. And then as you get moving, it goes away. So it's the opposite of most arthritis, and it's good to be able to kind of differentiate between those things. And of course, mood. I mean, I think we can make people sadly depressed, anxious. I think breast cancer can do that on its own before I even get in the room. And so these are important things to recognize from our hormone or anti-hormone treatment, which I prefer. Then there's the really rare stuff, which it happens thankfully very rarely. Things like clots in the legs or clots in the lungs, which is very rare. It's about the same as the pill, but we do talk about it a lot. Thinning of the bones, so osteoporosis. And you mentioned the last webinar was on exercise. Exercise is going to come up today, sadly, as well, because exercise is the antidote to a lot of things. Hard to do, but very effective. So that's probably a good start. Sounds pretty hideous, doesn't it?
It does. Well, a couple of times now you've said that these are the things that I'm responsible for. These are
Yeah.
the side effects that I dole out. It sounds like you have a very personal stake as a clinician in the sorts of ramifications that there are in your patients for decisions and treatment that you prescribe for them. How does it feel to be in that position, knowing that to help somebody, you're going to have to put them through some serious discomfort?
Yes, I mean, when I say that, and I do, you're right, I do use that when I'm seeing patients, but sometimes what we're trying to tease out is it what I've given you or is it something else? You know, menopause is a good example. Like, is this menopause from my treatment or is this menopause? Because we often treat a lot of patients as they travel through menopause. So, you know, I do use that analogy. Look, it's an extremely rewarding position to be in. I'll say that hopefully until I finish up this gig, whenever that will be. But I think it's about setting up what to expect. And there's a balance between scaring patients. I mean, you've heard what Katrina's had to go through. And Katrina, I suspect if we told you all of that on day one, you probably walked out the door and said no thanks. So it's about a balance between trying to explain, well, where does this fit in and why are we doing it? And most importantly, that if you need to change the plan, it's okay. You know, some people, if you tell them everything at once and then 6 months later you're deciding to change a drug, and the patient says, but you told me I had to be on that for 5 years. And so I think it's having some flexibility, both as the clinical team and also for the patient and their caregivers. Yeah.
And I mean, I think the first thing that Katrina mentioned was loss of control, feeling out of control, the feeling that something's going on inside your body that you can't stop by yourself is a very alarming feeling. How do you approach that in the early days when you're dealing with people who are coming to terms with what's going on inside them?
I mean, I think firstly just acknowledging it. I mean, I know that doesn't help, but you know, acknowledging that this is exactly the case. Nobody deserves to get breast cancer, and for the vast majority of patients I see, there's no reason why, except maybe you're female and maybe you're getting older, and those things on the whole we generally can't change. So, you know, I think acknowledging it. I think also sharing those feelings with your caregivers, whether it be family. Sometimes it's not family. Sometimes it's having a professional, whether it be a psychologist or your breast care nurse or you know, it's a bit like, you know, as you start, and we might use the word journey as much as people hate it, I think patients work out, you know, who's going to be a part of this with me. And that might change as the story goes on. So yeah, I think it's very difficult. And, you know, oftentimes, you know, patients will clutch to, right, well, I'm going to, you know, do something crazy and eat carrots for the next 6 months, or I'm going to, you know, join a gym and, you know, and some of that stuff is good and some of it might be a bit excessive, but because they're the things we can control in our life, right? This you can't control. So it's trying to give back some sense of control with some of the things we do. It's really common. Yeah.
So with menopause, I mean, look, it's got such a wide array of symptoms and experiences, and sometimes people feel as though they're losing their minds. It's different. I mean, it's another layer again to be undergoing it at an unexpected juncture of your life. Tamara has asked, what is the best way to cope with menopausal syndromes? I appreciate it's a broad question, but you're very experienced, so I target it to you anyway.
Well, I think the first thing to say to Tamara is, I mean, if we've brought a menopause on chemically, either because someone's before menopause and we put them through menopause because of the drugs we give, that's really tough because it happens quickly. You know, menopause, I do this every day in the clinic. You know, menopause happens over years. Your estrogen drops naturally over, 5 years. It's really fun. I'm going through it. And but you can do that really quickly to someone, and that means that they've had no time to get used to that. And so firstly, I would say is that, is it a situation where this is coming on really quickly? And at that time, you might need to add in extra help, extra drugs. I mean, we're good at giving drugs, sadly, but sometimes those drugs are to help because of the time cost we're doing it. The other thing I love to say is that, vacations are good for everyone and vacations are good for drugs as well. So if someone's having a really tough time with the menopausal symptoms, backing off. Remember, this is treatment that goes for a long time. This is not for, 2 months or necessarily 2 years. It's sometimes for many years. So sometimes giving drug holidays to tease out exactly what is causing what. I'm pleased to say we finally have drugs that help with hot flushes that aren't HRT, because obviously HRT is contraindicated for most of our patients. Unfortunately, they're still not on the PBS, so we have work to do, Annabelle. But these are great drugs that try and reset the chemicals in our brain that go off when we go through menopause or you get a drug-induced menopause. And they really do work. So we just need to make them affordable for patients. So there's definitely work to do.
That sounds like that needs to be on the PBS
Yeah.
stat. Linda, how expensive are those drugs? At this
$70 a month, which, you know, is for a lot of people, that's another, I mean, you know, this breast cancer diagnosis is usually a financial taxing event. So, but for a lot of my patients, they buy the first $70 and then they get to the end of the month. And if it's been that useful, if it means you can sleep, if it means you can go to work, you know, then you count how many coffees you're not allowed to have in the next month. And usually that's how they work out how to afford it. But yes, you're absolutely right. We've got to get that on the PBS. It should be coming.
Linda, like, can you just tell us what the name of that drug is? Just, I mean,
well, one of them, the one that is out there now, is called Fezolinetant or Veoza. Veoza is probably the easy way to say it. And you know, you can certainly talk to your teams about that if you haven't already. There are other drugs for hot flushes, I should say. I've been giving them for many, many years. But the dumb thing about the other drugs is they've been designed for another purpose, and it turns out they help hot flushes. I'd prefer to give a drug that's just for hot flushes. Right. So we're getting there. We're getting there. And there's another one on its way that looks even better. So yeah.
Okay, well, that's very encouraging, Belinda. Although I must say I have an affection for these drugs that accidentally turn out to be good at something else.
True.
It's always a good moment. Okay, so this is the point where I'm going to throw some questions back to you in the audience. I'm going to ask all of your question on the topic of side effects from treatment, just to find out where you're all at. So remember before I was saying look for the three little dots at the bottom right-hand side of your screen. One of those has our poll on it, so hover over that. And the question to you is, what side effects have you experienced from breast cancer treatment, if indeed you are one of our participants who's had or is having breast cancer treatment? You can click on one or as many options as you like. The sad news is that there may be multiple answers to this question. The options are fatigue, hair loss, nausea, vomiting, joint pain, lymphedema, skin and tissue changes, menopausal symptoms, and emotional and cognitive effects. Katrina, I'm afraid we haven't included nose scabs on the list, but we do acknowledge your experience with that particularly upsetting side effect. It is a real circus out there, isn't it? We'll come back in a few minutes to let you know the results of the poll. But in the meantime, I'm going to take you now to a video. You know that breast cancer trials, I mean, the whole point of breast cancer trials is that it conducts clinical trials with participants who are giving their time and experimenting at various stages of the trial process to help themselves and those who are coming along down the track. It's a very generous thing to do. These trials are investigating new and better treatments that have fewer side effects. So I'm going to play you a video now that's about a new study that has opened that's called Perspective. Let's take a look at Perspective.
With cancer, we want to cure as many patients as possible, but we also want to do it with as little treatment as possible. Perspective is the international version of the PROSPECT study. PROSPECT was a study to test the hypothesis or the idea that by using MRI scans, we could identify a substantial group of women with early breast cancer who could safely emit radiation. 201 patients were treated on study without radiation. The recurrence rate in the breast without radiation was only 1%, which is far less than we would expect. A very encouraging finding that led us to develop the Perspective trial to see whether we can replicate and validate the findings. Perspective is a study for early stage cancer. Women over 50 with a cancer that seems to be less than 2 centimetres in size, is confined to the breast and not in the lymph gland, and isn't the triple negative type, and then are treated with this additional imaging and then hopefully minimal treatment, omission of radiation. The whole area of optimization or de-escalation is vitally important. No treatment is without side effects, but most people are happy to have it on the basis that it might help them. And they often put up with the impact of treatments on quality of life. But if this trial can replicate what we found in Prospect, that we can reliably find a group of women who can safely avoid radiation, it would be a very good thing, and it's something that could potentially change the way that breast cancer is managed. I'm very grateful to those who have made Prospective possible, and we will continue to work very hard to hopefully confirm the results of Prospect are applicable widely.
Okay, well, it's always amazing to see what brilliant minds are up to. There's always something on the go at breast cancer trials. I'm going to introduce now Professor John Boyages, here I go again, who I'll remind you is a radiation oncologist at the Icon Cancer Centre in Sydney, Adventist Hospital. So, John, people, I guess, immediately think about chemotherapy and side effects when they think about cancer treatment. Can you talk about the most common side effects you see in the clinic as a radiation oncologist?
Sure. Look, thank you. And a lot of you in the audience have had radiation therapy, and I don't want to bore you with all the side effects that you've been through. And Katrina's mentioned those, redness, dryness, and so on. What I see every day in my clinic is fear. I see fear of recurrence. And there's three things that I particularly see. One is hardness around the lumpectomy site. Now, the patient thinks, oh, my lump has come back, my cancer has come back. But usually it's where we've given extra dose of radiation, or it may be where the surgeon has removed a piece of normal tissue in the breast cancer and has caused scarring. So that's the first thing. And most of the time, most people beat breast cancer, and breast cancer doesn't come back in the breast. The second thing is swelling, and we can talk a bit about that later. I think I'm here also for my lymphedema expertise. I set up the Alert Lymphedema program. Keelan, so another radiation oncologist, set up the lymphedema program at Macquarie University. And a lot of the time we see swelling of the arm, swelling of the breast. We can talk a little bit about that later. And a lot of that is temporary. It happens soon after radiation therapy, soon after surgery, but other times it persists. Now, the third thing that I see every day, and it's not well written about, and people blame me for everything. So if there's something going on the skin or the leg, it's due to the radiation. And
that's interesting, because I thought it was all Belinda's fault.
Yeah, well, I'm constantly saying, no, it's not the radiation. And like Belinda, we've got to untangle what could be radiation and what's not. But one thing I do see, and I've got a real interest in, is breast pain and chest wall pain. And I've done some research at Macquarie University. And what we have in the chest is we've got the ribs, and then we've got the breastbone, that's called the sternum. And in the middle of it, we've got cartilage. And it's a bit like the knee cartilage. You've got the leg bone and the thigh bone, and they're joined up with the cartilage. Now, what happens, our chest is a bit like a piano accordion. You've got the red bits, which are the bones, and the sort of white spongy bit. And we breathe like this. We cough and breathe and do things with our chest. Now, what happens after lumpectomy, after mastectomy, even without radiation, after radiotherapy, a woman tends to protect her breast, and men, of course, some men with breast cancer. And then they come to me and say, I've got breast pain from the radiotherapy. They fear recurrence. Most of the time with gentle palpation, I realise it's not the breast that's the problem, not the scar. But if your audience can find your breastbone, go out about 4 inches, press along a line, almost like the bra line. A lot of you, mine's a bit tender too, will find that your cartilages are a bit tender. And that's called costochondritis. And that's the most common, I see it maybe 25% of the time in any one clinic. And I teach patients, I can very quickly say, get into a door and stretch your chest, get one of those orange elastic bands and stretch, see your personal trainer. Most pain tends to be related to surgery or the radiation or the costochondritis, and usually it's not cancer. But if someone's worried, if you're worried out there, of course, see your doctor, your surgeon, your oncologist, and I had a phone call today, emails, patient feels her breast has changed. We're organising an urgent review, an urgent ultrasound. It's usually just to calm the waters. Most of the time, it's not a recurrence.
Okay. Two quick fire questions for you, John, specifically from people who have written in. Sally, who's obviously alert to your expertise in the field of lymphedema, has asked, is it pretty much massage and painkillers? Is that the main options?
Well, look, I think a lot of your viewers know that I've published this book recently, Lymphedema Taking Control. I'll give it a free plug. All royalties go to the Alert Lymphedema Program for research. But look, pain is not usually a significant feature of lymphedema. If you do get new lymphedema and pain, see your oncologist. Let's do some scans and make sure nothing else is going on. But really, there's a lot that can be done. Early detection is the most vital thing. If you're at risk, if you've had an axillary dissection, axillary radiotherapy or radiotherapy above the collarbone, really important to have 3 or 4 monthly bioimpedance checks, what's called LDEX, an Australian company. Takes about a minute to do the test. But the mainstay of treatment is compression sleeves, compression garments, massage, and of course, exercise is very important as well, and weight control.
Okay, Christine has asked, can you get rid of lymphedema with surgery? And she also, while she's got you, if the fluid in the arm will ever go.
Look, if we're talking about fluid in the arm, as in terms of lymphedema, we can get fluid collections in the armpit, which tend to be temporary. It can be a fluid collection, what's known as seroma. It can be a hematoma or a bruise inside the body, and that can persist. But if it's in the arm, unfortunately, what happens, the more you leave it, if you don't detect it early and you get swelling, then that lymphatic fluid can stimulate fat cells and deposit fat in your arm. Now, I've got a whole chapter in my new book, Lymphedema Taking Control, talking about this. And at Macquarie University and elsewhere in the country, we've introduced surgery, liposuction for lymphedema, lymphovenous anastomosis, and so on. But it's for very select patients. See an accredited lymphedema therapist or see your oncologist or your surgeon to discuss this further.
Great. Thank you so much, John. I'm going to turn my gaze on Keelan now. Dr. Keelan Burns, a radiation oncologist from Melbourne at the Peter MacCallum Cancer Centre and Icon Cancer Centre as well. Keelan, we've got a question. Welcome for starters, and thanks for being with us. Diane has sent in a question. She wants to know, how long does muscle and joint pain last after radiation treatment, and does anti-inflammatory medication help?
Yeah, thanks for the question. And I think probably John has sort of covered a few of the potential causes, but it can often be multifactorial in terms of muscle and joint pain, both with radiotherapy, but in combination with systemic therapies like endocrine therapy and also surgery. And generally would say sort of radiation effects on the muscle or joint would be in or around the irradiated area, so the breast and the nodal areas if they get treated. But as John mentioned, sort of either some lymphedema or inflammation would probably be the most common cause of discomfort in the muscle and joints. Or even something like positioning, getting in that position for radiation on a daily basis can sometimes trigger shoulder issues. And very rarely some firming up of the tissues can cause some ongoing pain, or even little hairline cracks in the front part of the rib cage due to weakening of that. So it would really sort of depend on the sort of causative nature of the muscle and joint pain to the sort of duration. And in terms of that, similarly with anti-inflammatory medications, we don't sort of prescribe them too often unless it was very sort of severe issues. And very occasionally we can get sort of muscle inflammation, myositis or osteitis, which is inflammation of the bone, where they may need some steroid medication to try and calm that down, but that would be a very rare occurrence. And then also things like non-pharmacological things like physiotherapy, exercise are very important to try and help with any sort of muscle and joint pain.
Okay, all right. Now, I mean, Katrina mentioned straight away this sore, dry, red skin, and John mentioned that as a very common side effect before. Sharon's asked a pretty smart question, which is like, is there a way that you can prepare? How can you keep your skin healthy before and after radiotherapy?
Yeah, that's a great question. With radiation, there generally is a sort of 10 to 14 day lag effect. So we don't often see a huge amount of side effects straight away. And I think most radiation centers would often have radiation nurses that would guide patients through skin care and how to sort of prepare the skin before the radiation side effects declare themselves. We have started at the time of simulation, so a couple of weeks before starting the radiation, often give ladies moisturizing cream so they can get involved in the sort of preconditioning of the skin just to try and minimize any dryness that we can cause. And also sort of looking at different types of treatment for skin reactions. So things like Meptil, where we put a cling film barrier. There was some good data out of New Zealand showing that is good at reducing down grade 3, so peeling of the skin side effects, and also sort of barrier silicone gels like Epsom can be helpful with that. And then finally, occasionally there can be sort of itchiness particularly in the V-neck area, so that sort of upper inner quadrant of the breast, and it's often related to previous sun exposure. So ladies might have sort of freckles in that V-neck area, and then get a sort of dotted rash, which can be quite itchy and irritating, and that can sort of be very well treated with some topical steroid medications to try and calm that down. So it's important that we recognize that and be able to treat it as soon as possible.
Also, past exposure to sun makes those side effects more pronounced?
Yeah, well, particularly with that folliculitis, so that inflammation of the follicles of the skin. So generally, our skin reactions are sort of quite confluent within the radiation field, so all over the breast. But I'm sure there's hundreds of the patients online that have experienced maybe a little bit of itchiness in that sort of upper inner quadrant. It is quite easily to sort of pick who might get it, depending on what their skin looks like in that area. And but there's also been a few sort of advances with radiation, trying to concentrate the treatment over maybe 3 weeks is shown to be less impactful on skin reaction as well. And obviously there's other things like using chlorhex as a bit of a preparation for the radiation as well, which is like an antibacterial wash. There's a little bit of small data emerging. Maybe that might be useful preconditioning for the skin.
Oh, okay. That's interesting. So a few minutes ago, Belinda said something that I found surprising, because I always just thought, well, if you're prescribed drugs, it's got to have those drugs until it's finished. She said you can take a drug holiday. And I'm sure that would have been interesting to some of our participants this afternoon. Does the same, Joe providentially has asked this question, is it safe to give your body a spell from treatment in radiation as well if the side effects are getting too overwhelming?
Yeah, that's another great question. It is a something we used to do a bit more frequently in terms of needing to give patients breaks during the radiation. Again, with the lag effect, it's often a couple of weeks before we begin to see some of these sort of skin reactions. And it is possible, particularly, and I guess it would depend on the clinical situation. So obviously you'd need to sort of discuss this with your oncologist if you did want to take a break, but it would be fine to give patients a break for a week or two to allow any side effects to declare themselves. It often doesn't give a great recovery at the time because of that lag effect. So often you give them a break for a week or two and their skin or swelling gets worse during that period of time. But it can help in terms of sort of 2 or 3 weeks after completion of the radiation, sort of reducing that risk of peeling. And particularly in the sort of last year or so, there is quite a lot of data coming out in terms of reducing down from 5 weeks to 3 weeks. And even if we're just treating the whole breast, maybe even concentrating it down to 1 week. And in that situation, often ladies don't get their side effects till sort of a week or two after the radiation. So it is becoming a bit less common that we need to consider giving patients break during the treatment.
Okay, so I mean, if you had treatment for 2 or 3 weeks and then you had the lag and then started experiencing these side effects and found them unbearable, if you took a break, there'd also be a lag for the relief to arrive. If you then restarted, I mean, sorry, I'm just asking whether there's a point where the symptoms improve even after you've restarted.
Yeah, it's yeah, that sort of lag effect. So whatever you're doing at the time is probably helping a week or two in advance. So particularly say if you saw somebody at 4 weeks and they had quite bad skin reaction and you're worried they were going to peel, you could often stop them for a week or two and allow that to declare itself. So it might be just some dry peeling, and then it will begin to recover, and then you finish off the week or whatever is remaining of the radiation treatment.
Okay, understood. Thank you for clearing that up. Okay, I think we've got a little bit of feedback from the poll that we conducted a few minutes back. Okay, so the most common side effect that's being reported from participants in this session is fatigue, followed by emotional and cognitive effects, then joint pain. They're the top side effects that our participants have experienced. Katrina, I'm going to come back to you. Does that sound familiar to you, like those common side effects? I know that you're a participant now in the consumer advisory panel. Do those sound like the most common ones to you in your experience?
Absolutely, particularly the fatigue side effect. Personally, full-time working mum, I was tired as it was. So you throw cancer into the mix and a whole lot of treatment. It's very pronounced during that time and throughout the journey. The emotional and cognitive effects long term, I think, again, from a personal perspective, so they can be difficult to manage, but I think the key word there is you can manage them. It's just a matter of finding the right support networks and what works for you.
And Katrina, I mean, in your position, you were dealing with the shock of this diagnosis and everything moving so quickly. You were also managing the reactions of your husband and working out how to manage talking to your children about it. I mean, how do you deal with processing all of those emotional loads as you're feeling emotionally dysregulated at the same time?
Being proactive as opposed to reactive from a mental well-being perspective, I think, is really important. I had a pretty honest conversation with my oncologist about 5 weeks into my treatment, and we discussed the option of a referral to a psychologist. Now, the old me would probably have been hesitant and no, I don't need that. But I think from a control perspective, you do need to relinquish that throughout that period. And I accepted that recommendation and was referred through to Dr. Charlotte Topman, who I'm sure
I know her.
yes, that name would be very familiar to a lot of people on the call this evening. And I'm still seeing Charlotte, and I'm 3 years down.
And so I'm just being nosy here, so tell me to butt out if this is too personal, but is that cognitive? Is it talk therapy? What did you find was useful for you?
Yeah, so a lot of it's coping mechanisms, particularly when I was in the thick of my treatment. So the frequency of my sessions with Charlotte were, once a month. as the journey's gone on and we've established that relationship and I've taken a lot of her advice, I don't see her as frequently, but I think it's important to note, as to John and Belinda, I think have mentioned throughout the call, it's the fear of reoccurrence as well for patients. Generally creeps up post-hospital treatment because you're out of the hands of the specialists and you're just back to your normal routine. So that's where else Dr. Charlotte has helped.
Okay, so you found Dr. Charlotte Tottenham, who sounds like she was the right person for you to find. How did you embark upon that search? How do you find the right person? It's not always, you don't find the right person the first time around. And Leanne particularly has asked about finding good resources for emotional and psychological support. Where do you start?
Yeah, I think I was lucky in the sense of I was able to have that conversation with my oncologist, and for Charlotte and I, we just clicked straight away. And, I found a psychologist who specialises in psycho-oncology and who had a personal experience herself. So when you talk about sitting in front of somebody that completely understands what you're going through, boy, was it a luxury that I had Dr. Charlotte. From a resource perspective, I think it's important to note that getting in to see a psychologist, firstly, can be quite difficult. I know, Annabelle, you've mentioned around the financial strain that breast cancer treatment can produce for patients, and appointments like that can be quite expensive. So another resource that I did find extremely helpful, and again, it's Dr. Charlotte Totman. She has done a series of podcasts, What You Don't Know Until You Do, upfront about breast cancer. It's a 2-part series of podcasts. I found those incredibly helpful during, again, the thick of my treatment too. Free, so, and readily available.
That's a really great point to make, I think, Katrina, because sometimes, people respond to different things, different kinds of therapy, different ideas. When you find something that resonates with you, it is can be a magical feeling. And I guess podcasts and books and sampling these different approaches and having a listening ear as to what strikes a chord within you is a really sensible and smart thing to do. Thank you. Belinda, coming back to you now, we have had so many questions about fatigue. We know that fatigue is the number one symptom side effect that's been reported from participants. So give us everything you've got on fatigue and what patients can do about it, because it affects so much, doesn't it? Including your capacity to pursue enthusiastically all the other things that you're supposed to be doing to help yourself.
Yeah, there's no single drug answer here, which won't surprise anybody. And I think it's because we need to work out where the fatigue comes from. Oftentimes what I think of this is that you've got to work out a new routine. Now, is this a new routine because you're about to undergo 6 months of chemo? And can we help predict when the fatigue is going to be at its worst? For example, some chemotherapies, you have a really bad week, then you have a better week, then you have a good week. Well, that's what we say. So in that bad week, don't plan a whole lot. I always say outsource stuff when you can. So, use your friends and family, get them to drive kids places, drive you places. Get them to exercise with you. It's a good way to socialize, but see them at the same time. You can only eat so many lasagnas that everyone wants to cook for you. So I think, working out how to use your team around you, which might be a very small team for some and a very big team for others, and trying to be able to have a sense of what is expected when the fatigue is at worst. And also to plan the good stuff. If you know you're going to have a good week on chemo, that might be the week you want to plan, you take the kids out, or you plan that weekend away. Much harder when we're talking about, endocrine therapy that we've mentioned a few times for years and years. It's about saying, well, settling into these drugs for the first, I often say 3 months is really key. And keeping fit during treatment is really key. And it is hard. Exercise is hard for everybody, no matter what people say. But trying to create a routine where exercise is part of it, whether it be what John said, the stretchy bands, whether it be walking around the block, whether it be going to the gym, running a marathon, I don't care. It's probably got to be a bit of everything. And, you already don't have, there's a chunk of time we just took away because you've got to come for treatments, but trying to then slice that into your new routine. Diet is key, minimizing alcohol if you drink alcohol. Finding out where does work fit if you work. Have I got to cut work in half? Have I got to stop work? Do I even know? Employers I find on the whole really supportive for patients, which is excellent, as they should be. And then, of course, it's about if it's ongoing treatment fatigue that, really can't be abated with these kind of lifestyle things, then reassessing with your team, is this, the drug holiday? Is this changing the drugs? Is this, having a discussion about whether or not, you need a dose reduction? So there's no one single answer for fatigue. I wish there was, and there isn't. But, there is good news at this. Oftentimes people do find this routine, and it changes as the course goes on, as Katrina was just saying, she saw Charlotte a lot more in the beginning, and now it's kind of, less frequent, and that's a little bit the same. So I don't know whether I answered it, but yeah.
No, you answered it beautifully. Thank you, Belinda. I'm going to completely change things up now because Kate has asked something completely different, which is she wants to know what are the best remedies for itchy skin and poor quality fingernails and toenails following treatment. What do you know about the nails situation?
Okay. Well, the nails could be a few things. The nails could be chemo, or the nails could be a targeted therapy, something like trastuzumab, Herceptin. That's a really common thing to give you brittle nails. Think about the nail. Anything that grows quickly, chemo likes to tear apart. So your hair, your nails are one of those things, the inside of your mouth, your gut. So if it's chemotherapy...
We're talking about nails kind of like cracking off, splitting?
Yeah, well, it can be anything. It can be they stop growing, they get brittle, so they break. You can find you get infections under the nail because they're starting to lift. None of this sounds great. So what can you do? So keeping them nice and clean and dry is a really underestimated importance. So it sounds weird. A lot of people go in there and really scrub the nails out, but if they're starting to lift, you've actually got to dry underneath them. So get your hairdryer out and dry underneath, because if you get moisture in there that doesn't come out, then you can start to get some kind of fungal infections in there.
Hairdryer, okay.
I know it's crazy. Don't burn yourself, but yes. The other thing is letting if you've got closed shoes all the time, so, letting your feet air and things. Because yes, our chemo treatments do damage the nails, and that can be painful actually, sometimes painful enough to stop the treatment. Hair and nail formulas, those really expensive hand creams. I find just the thicker the hand cream, if you can turn it upside down in the pot and it doesn't fall out, use that over something really thin, and use it often. I haven't got that. Pardon? Oh, I just lost you there.
Oh, I was just saying, I'm just mentally noting the tipping a jar of cream upside down. If it if it falls out,
yeah, it's good. Yeah, if it runs out of the tube, it's no good. The first part was the skin. Well, the skin. So dry skin is common when we put patients through menopause, in particular severe menopause. Chemotherapy dries everything out. And so again, I mean, that is kind of, moisturizer, if you're in the sun, you got to wear, you probably should be avoiding the sun, certainly while you're on chemotherapy. So making sure you cover up.
Okay.
They're probably the key things with the skin.
All right. So we had a conversation before about with Keelan about stopping and starting treatment and how long it takes for side effects to abate. Can you just give us an overview from your field of expertise about how long after treatment, Suzanne is asking this question, do side effects disappear?
Suzanne, frustratingly, it depends on therapy. And Katrina's highlighted this a bit. If there's a 6-month plan for chemotherapy, there's going to be ups and downs in that. But even on the day you finish the chemo, a bit like what Keelan said about radiotherapy, it's not over then. And actually for chemotherapy, it's not over even. I usually say you've kind of got to add on the same amount of time I treated you, before really you feel like you're coming out of that hole. Now, that's not to say that you can't be enjoying life, back to work and things like that, but, it can be months. So just be prepared for that. Don't plan your holiday the day after having your last chemo. In terms of the endocrine treatments, this is more the kind of long haul, the marathon. So, of course, some of our treatments, for example, tamoxifen is a very common treatment we give patients. It takes about 6 weeks to get into the system. So guess what? It takes about 6 weeks to get out of the system. So if you're taking tamoxifen and then you come off tamoxifen, you've got a few months there before you start to really get it out of the system. The aromatase inhibitors, so those that squash estrogen completely, they're out a bit quicker, but the effects of those tend to last, a bit longer as well. So usually I would say, a few months. Yeah. Yeah.
Okay. So I'm picking up from you, whether it's fatigue, side effects, just don't bind yourself into plans, give yourself a little bit of leeway and grace to allow yourself to cope with these things. John, I'm going to come back to you now. Leah has asked a question, which is, what is the reason for cording and what is the best treatment? And because I'm a fool, I would also like, for my purposes, for you to tell us what cording is. Oh, that's your book. Okay. John, you are on mute, my friend.
Sorry about that. You can see that guitar string almost, when this lady stretches her arm up, it's like a guitar string, to be honest, and it often extends from the armpit, sometimes usually down to the elbow, but sometimes down to the wrist. Happens in the first few weeks after surgery and radiation. Can last 6 and 12 months. Can be very difficult, annoying. Women find it hard to, Katrina's nodding here, elevate their arm or pick things off shelves or tie their bra strap and so on. And a lot of research, I do a lot of research with Cheryl Brunel, who's an amazing therapist at Harvard Uni. She's done a big meta-analysis, which I've written about in the book, and it's thought to be more common in younger women, women who have axillary clearance, women who have radiotherapy to the axilla. And in her research, it also has been shown to be a risk factor for lymphedema. So I think it's really important if someone does get cording, maybe 2 out of 10, to also go onto a program of screening with that LDEX that I mentioned earlier. See an accredited physiotherapist or lymphedema therapist, massage your arm daily, massage your breast to keep your breast moisturized, particularly after radiotherapy. Put vitamin E cream or moisturizer, Mugu, massage up towards the armpit every day. The therapist will do stretching exercise, massage, laser therapy. Got to keep trying different things in our toolbox. It eventually goes away.
Okay, all right, thank you. Got a couple of quick fire questions from you on specific issues. Vicky has asked, has there been much research into hair loss following treatment, and how can you avoid losing hair on your head if you possibly can?
Yeah, look, it's a problem. Radiotherapy affects hair loss in the treated area. So when I talk to women when I give breast radiotherapy, I say, look, you may lose a little bit of hair under your armpit, and they say, oh, thank you. But generally it's not a problem. It's more of a problem in Belinda's area with chemotherapy, often intensive chemotherapy. I think, Belinda, some of the new immunotherapies as well can be a problem and sometimes cause persistent hair loss. And people have tried various bits and pieces, but I think just time, most women's hair grows back.
Okay. And just quickly, Sarah's asked about breast tenderness and swelling, and this is from the Are We There Yet school of how long does this take to go away once treatment finishes?
Yeah, look, I'm doing a lot of research on breast edema at the moment, or breast lymphedema. It's usually it's temporary, but a lot of the times it persists, particularly for women with cancers in the lower quadrants of the breast, bigger breasted women, women who have taxane chemotherapy, women who have axillary clearance. Again, see a therapist, massage, self-directed massage. If it persists, see a specialised unit like the Alert Lymphedema Centre, where we do fluorescent imaging called ICG. We can work out where the fluid is trapped, and we can then give a roadmap to patients, a bit like Google Maps, tell you where to go with the massage rather than going in all directions. So that's very important. The other thing is I often give women antibiotics to take, a script to take with them overseas if they're overseas. An edematous breast is more prone to cellulitis or mastitis. Don't blame the radiation. If it happens months later, can happen, as Keelan said, 10 to 14 days later. If you get a red hot breast and you feel unwell, it can be cellulitis. And it's really important to get some antibiotics from your GP or your oncologist or your surgeon, put them in your handbag, take them on the plane with you, and just have them there just in case. And I have seen women where it does happen overseas, and you've got it there, start taking the antibiotics such as Keflex straight away.
That's such a great tip, John. Thank you. And speaking of Keelan, you're the next one in my sights. Keelan, Jolly has asked, at what point would radiation treatment stop if burning and blistering occurs? And if continued, does that increase the risk of lymphedema?
Yeah, thanks. Well, thankfully, sort of burning and blistering is becoming much less common with our radiation technique. So improved methods of delivery, concentrating the treatments into shorter durations, and improved skin care. But it still can happen, and particularly on occasion, it's more or less common these days that we need to use bolus, which is a material we put over the skin during the radiation to heat up the skin. So often that can cause more severe skin reaction. And also, if ladies have a large breast volume, and particularly if there's any sort of creases under the breast or at the side of the breast, they are areas that can get a little bit more prone to blistering or burning. And very rarely, we might sort of pick up maybe 1 in 1,000 ladies who has a sort of inherent sensitivity to radiation, where for some reason they just get a lot more pronounced side effects. So it's important that we do monitor these ladies during the treatment just to make sure everything, if they are getting side effects, it is as expected and not too sort of out of the ordinary. And then in terms of the risk of lymphedema associated with that, they often can go hand in hand. I guess if you're sort of treating large volumes of breast tissue, you're probably a little bit more common to cause some breast lymphedema with that. And similarly, if you're just more prone to getting side effects from radiation, it might be linked in that way as well.
Right. Okay. Smashing through it now. Megan wants to know about nausea. Any tips on how to soothe that?
Yep. So extremely rare that we cause nausea with breast radiation. It's more when we treat the brain or upper abdomen with the liver and the stomach. But we do sometimes when we go near the esophagus can cause a little bit of nausea. So maybe about sort of less than 1% of patients might notice some nausea, and it's quite consistent with the radiation treatment. So a couple of hours after. And then in terms of managing that would be it's usually very mild if they do get it. So sort of dietary things like avoiding big meals or spicy food, alcohol, things like that, all the good stuff. And maybe things like ginger tea, peppermint tea can help with nausea. And then very rarely would have to give sort of medications to help with nausea like Maxilon or ondansetron. Yeah.
Okay. We always end up at ginger tea in the end, don't we, Keelan? Hazel has asked, what help is there and what would you recommend for living with lung damage if you end up with lung damage as a result of radiotherapy? How common is that and what can you do about it?
Yeah, so the radiation sort of impacts the lung in 2 ways. First, in the sort of month or 2 after radiation, there can be a sort of phenomenon, what we call pneumonitis, which is inflammation of the lung. Again, with sort of modern techniques, that is becoming less common. Things like breath hold, arc-based therapy, where we can avoid the lung quite nicely. But if you do get pneumonitis, it's often a bit of a dry cough or some shortness of breath, often very mild. Again, probably less than 1% of patients when we're just treating the breast alone, and just settles up by itself. Occasionally, we might need to give an anti-inflammatory if it is very bothersome. And it's, shortness of breath and a bit of a dry cough. It is a bit more common if we're treating nodal areas like the internal mammary chain, the base of the neck, where we treat a bit more lung in that regard. So maybe sort of 2 or 3% in some of the studies. There's also what we call lung fibrosis, which is almost like a bit of a haziness of the lung or some scarring of the lung just under the chest wall. Again, becoming less common with our advanced techniques. And often it's just sort of picked up asymptomatically. So if ladies have a CT scan for another reason, they may just notice a little bit of change just at the just under the breast area, or a little bit of scarring in that area. And often it doesn't really impact their sort of breathing function. There has been, particularly in sort of with some of the more modern medications like TDM1, which is like a Herceptin and chemo conjugate, a little bit of data that there is more risk of causing pneumonitis. It seems to be a bit separate from the immunotherapy cause of pneumonitis as well, but certainly with TDM1, we occasionally see ladies with a little bit more severe either lung fibrosis or pneumonitis, and then would often need to treat them with anti-inflammatories or get them to see a respiratory specialist to get involved and help with that.
Right. Okay. Thank you for that very comprehensive response, Keelan. Belinda, I've got a video question from a participant called Julia. I think the other non-negotiable endpoint here, apart from ginger tea, is exercise, and that's what Julia's question is about. So let's have a look.
Hello, my name's Julia, and my question for the panel is about delayed onset muscle soreness from exercising. It seems to be since I've had my breast cancer treatment and my ongoing endocrine therapy treatment that I can't exercise without pulling muscles. Just something as simple as a walk is really destroying my body. I am finding this very hard to deal with, considering I find my exercise to be such a big part of my health. So I was wondering about some expert advice on supplements, or is there any research of why this is actually happening to me? Thanks for your time.
Thank you so much for that question, Julia. Wow, how interesting. Belinda, do you have any thoughts for her and us?
Yeah, I mean, that's tough because she's trying to exercise and yet it's actually causing her more problems than help. So the first thing I would maybe try and work out is this related to the drug? So hence the holiday is a huge fan of mine. I'm going to come back to that. You know, it's interesting. She mentioned supplements. I mean, we do find interestingly that things like magnesium help, especially if they're cramps. Especially a lot of people get them at night. And magnesium, even weirdly spraying magnesium on your legs. I mean, it sounds voodoo, but it seems to work. Patients of mine swear about it.
So it helps a bit with anxiety and sleep and stuff as well.
It can help. It can help with sleep. You're very lucky if it helps with sleep. The other thing is whether or not the type of exercise. So if it's particularly muscle cramps and things, whether or not changing back to that kind of resistance training. So even just starting with some stretches rather than going out and having a big walk. That kind of thing, seeing an exercise physiologist and getting them to assess you and work out, are you sore in any vulnerable parts of you where you might have had a knee injury before and now that's feeling worse. So yeah, I agree. It does sound a little bit odd. And if the drugs, the beauty of this is if the drug's to blame and you stop the drug for a bit and it goes away, we know it's the drug. So then we work out, do we change the drug? Do we try and find something else? So that's probably a good start. I mean, simple things like non-steroidal anti-inflammatories, your Nurofen, your ibuprofen, that might help. It's not going to solve the problem long term, but it might help to relieve, what that lady is going through. So, that probably needs a bit of a team. That probably needs all of us, to be honest. She might need to come sit down with the team and really try and tease it out. Yeah.
Okay. This is yet another recommendation for joined up care, right?
Yep.
Yvonne has asked, while we've got you, about neuropathy. What can help with that? And also maybe just talk about what it is.
Okay, so this is different to the nails. Okay, this is damage to the nerves at the end of your fingers and the end of your toes. And if you're unlucky, it goes up your fingers and up your toes, which we try and avoid. And this comes directly from the toxic effects of some of our chemotherapies predominantly. Interestingly, some of our targeted therapies, we do see it in some of the newer treatments, but that's actually pretty rare. Much
So
more
we
likely.
talked about sort of tingling, numbness.
Yep, perfect. Usually starts with a bit of tingling, and then it can actually go to numbness. Sometimes it's pain, like when you get into bed at night, you put the sheets on and you can't stand the sensation of the sheets on your feet. And so this is tough. So there's a couple of things you can do. The first thing to say is that preventing it, as Katrina mentioned, is better than treating it. So how do we do that? I mean, we need to give the chemotherapy. So in the old days, everybody got, you know, these ice booties and ice gloves, and we're really good at giving it. And then we kind of stopped giving the booties, and then we threw them all out in COVID. And now we ask patients in most institutions to go and buy them, and you can buy them. They're about 150, $200 on Amazon. And you bring them in your own little esky, and you put them on before the treatment, and you sit there freezing cold hands and feet, and you wear them for a couple of hours during treatment. And that significantly reduces the risk of the nerve mesh damage while you have it. If you can't do that, you can't get the glass gloves. Actually, stupidly, this sounds weird, but putting a very, very tight surgical glove, one that is too small for your hand, I can't help the feet. The feet may be something like runner's socks. During treatment also miraculously helps. And the way it helps is because it's stopping the chemo getting to those very teeny tippy bits of your hands and feet. It doesn't reduce the efficacy of the chemo, but can certainly try and avoid getting this nerve damage. Even then, though, patients often still get it. And so that's when, you know, I say to patients, if it's starting to bother you, if it's there all the time, that is actually a really easy thing. We often have to either pause the treatment, stop the treatment, or reduce the dose. I think what's harder is what do you do if you've got it and you're a year down the track and you're still being troubled by this, which about 10% of patients do, sadly, a year later still have these problems. Then it's about saying, well, if it's pain, we have drug treatment to help. You know, you're going to sick of me saying exercise, but if you move your, you know, digits and feet, even just improving circulation down there seems to help in the recovery of this and avoiding the other things that cause neuropathy. So if you can avoid, you know, getting diabetes, you know, alcohol is a cause of, you know, this. So minimize your alcohol. You know, yes, keeping your weight in the normal range. So and making sure that, you know, your supplementation of your normal vitamins is there. So yeah, I blabbered a bit, but that's probably the simple answer.
Oh, these are all such great little nuggets of wisdom and insight, Belinda. Just quickly, I'm going to ask you a question that's come through from Linda, who says she was really unprepared for treatment side effects and the impact on her life. What resources do you recommend patients to try and help them be as informed in advance as possible?
So if you can, bring someone with you to your appointment when we are going through this, and it might take you more than one appointment to hear it. It often takes more than one go to hear it. Having both, you know, information, you know, if you can in person or on telehealth, but also having written information about the treatment plan. There are excellent resources out there. If you are lucky enough to have a breast care nurse, then, you know, the breast care nurses are experts in this. They have done this many, many times. And so they are an excellent resource throughout the treatment and even after the treatment. BCNA, so groups like BCNA have some fantastic resources. Hopefully your team are giving you printed information, although I often say to the patients, you know, I'm giving you this, but the information at the back is not perfect. You can eat salad. Don't be worried about that. So some of the stuff in the printed information needs reviewing more often than it really is. And then, you know, I guess if we, like I said to you, for example, if we're talking about something like chemo and we say, you know, we think the first week is toughest, the second week, and if it doesn't really pan out that way, then that's time to go back and be reviewed and say, well, it's not in me, this is not working. I mean, just like the patient you heard with the aches, if it's not really going according to plan, then, you know, come back and be reviewed.
Yeah, something that I'm hearing really strongly from you this evening is just always be in a state of review and revise and change tack if there's something that's really seriously not working or causing terrible problems. John, we're racing against the clock now. I'm going to get everybody out of here in time for whatever they need to do at 6:30 Eastern time. John, there's been questions about a whole range of side effects. Really be interested to know what area of research right now are you most excited about in terms of relieving side effects of treatment?
Look, I'm old, and I've been in this game for 45 years. And when I first started, we were doing radiotherapy planning with pen and paper. The radiotherapy I've seen we're using today, particularly at Icon here at the SAN and elsewhere, is some of the best I've seen in my whole career. And we've just sent some amazing research called rapid arc dynamic planning, where the heart doses, the lung doses, are significantly lower than we see today. I've just chaired and authored a partial breast radiotherapy trial where we're giving just a tiny golf ball of radiation to the breast. The ladies don't even know they're having radiotherapy and no side effects. And as Keelan said, we've reduced our treatment from 7 weeks when I first started to 5 weeks. All my patients get 3 weeks, but some do get 1 week of treatment to the whole breast as well. And we're doing some really exciting stuff with the lymphedema program as well. Really exciting in terms of prevention and treatment.
Okay, that's awesome, John. It makes me inclined to ask you, Keelan, what you're excited about in terms of emerging approaches that you think are going to have a big impact on reducing or preventing side effects of breast cancer treatment.
Yeah, us radiation oncologists, we get very excited about similar things. So partial breast radiotherapy, definitely, it's a massive game changer. And it's probably one of the most significant changes in all radiation oncology, particularly the Florence trial, which showed 10 years of data showing a statistically equivalent control for ladies with sort of early breast cancer, so not spread to the nodes, but just localized and certain conditions, but significantly less toxicity, so about a sixth of the toxicity compared to whole breast, and particularly in terms of patient-reported outcomes. And another trial, which I think is probably going to shape trials as we go forward, is the Europa trial, which is still maturing, but on the 2 years publication earlier this year, it's a randomized trial randomizing ladies to 5 partial breast treatments over 1 week versus 5 years of endocrine therapy. And the quality of life study came out at 2 years showing no statistical impact effect with the radiation, the partial breast radiation. But obviously with the endocrine therapy, there was a significant reduction at 2 years, and these ladies would have to keep going for 5 years. So I think we do need to be sort of considered when we're thinking of de-escalation about what is actually impacting the patient's quality of life, and can we de-escalate better and give patients a sort of equivalent treatment that's much less toxic.
Yeah, I'm throughout all of these sessions, I've learned that moderating treatment and being targeted and deliberate is such a important emerging discipline and area of study. Katrina, I know that the breast cancer trials consumer advisory panel is quite influential in the kind of work that's undertaken by the group. Where would you like to see more research into the side effects of treatment?
Look, I think generally speaking, any sort of research that's going in to mitigate or eliminate both side effects and improve the quality of life for patients, full stop, is where I would like to see the research go into. You sort of forward think, particularly as a mother, and you think about generations to come, and if we can help those generations moving forward with less of a burden on both their mental and physical well-being, I think we'd all be sitting very proud of ourselves.
Okay, great. Thanks, Katrina, and thanks again for your generosity in participating not only in this panel this evening, but your ongoing work with breast cancer trials. It's enough to have been through the experience, but to have enough gas left in the tank to help other people is a really remarkable thing. So thank you for that contribution. As we know, breast cancer trials, there's a number of clinical trials that are investigating new and better treatments that have fewer side effects. I'm just going to quickly play you a video now about a study that's aiming to reduce side effects from chemotherapy treatment, which is called Optima.
traditionally with breast cancer, the way we treat it is often with chemotherapy and hormone blocking tablets. But we know that we often are giving chemotherapy to women who don't get a benefit from it. So what Optima is trying to do is to see whether a test on someone's breast cancer tumour can work out whether they might be able to do just as well without having to receive chemotherapy. I'm Dr. Belinda Kiley. I'm a medical oncologist based in Sydney, specialising in the treatment of breast cancer, and I'm also the study chair for the Optima clinical trial. So the Optima trial is looking at men and women who have been diagnosed with early stage breast cancer, who have got either positive lymph nodes or a large sized cancer with lymph nodes that are negative. They need to be aged 40 or over. The cancer needs to be hormone receptor positive and HER2 negative, and it needs to be someone who is fit enough to have chemotherapy. What we really are doing with de-escalation is reducing treatment but not compromising outcomes. So it's giving less treatment but getting the same outcome. So I've been working in breast cancer for many years now, and I see the side effects of chemotherapy, and I see people coming in and hoping that they don't need to have chemotherapy. So it'd be really nice if I could give someone chemotherapy and know that they're actually going to benefit, and it would be really good if I can say to someone, actually for your cancer, we don't think the chemotherapy is going to add any extra benefit. So it's going to be really exciting if this test shows that we can find those cancers that can safely avoid chemotherapy.
Okay, that's Belinda Kiley there with more de-escalation. I'm going back to our Belinda for the last question. We've had some feedback from our radiation oncologists about what they're excited about. I wonder if you could tell us what gives you the most hope about how current research and clinical trials might change the future experience of people going through breast cancer treatment.
I mean, I think you've already heard a lot of it, and Belinda just told you very well with Optima. Like, we've got lots of good drugs in breast cancer. We're lucky that we do. And you could give everything to everyone, but we don't want to do that. And, you know, at that time when you come into the room and you've got your diagnosis, the first thing most people say is, I need to start yesterday. And we take time to work that out. Sometimes we take weeks to work that out. But getting it right is really important. And what we're getting better at through clinical trials, and I would strongly recommend if there's one in your centre that you're interested in to ask about it, is trying to work out what is the therapy, what's the Goldilocks, you know, what's the right treatment for you. And sometimes that's about, you know, looking down the microscope. Sometimes it's doing a fancy test like Belinda's doing in Optima. Sometimes it's actually just giving a few weeks of treatment on your way up to surgery, which is a lot of what I do. And I reckon, you know, these are the type of things that will absolutely change the future of breast cancer. But the other thing is, when we design these trials, the best news is, and Katrina, you'll be happy with this, we're actually asking patients in the trials, well, what is it like to have the therapy? Because we didn't used to do that. We used to just say, it's got to work or not work. Now we actually say, and while you're on this therapy, what is it like to experience of that? And both of those outcomes are important. And they're not only important to the trial, but they're important to decide whether or not these treatments become funded and standard of care for future patients in Australia and around the world.
Well, Linda, I'm sure that you encounter people who, and I suspect this would be my response, they find out they're in this situation and they say, throw everything at me. Let's just absolutely smack this in the teeth. How do you encourage people to take a breath and take that time when taking time feels so risky?
You've got to give them time to vent that, and then you've got to try and walk them through why you want to give them something and why you don't want to give them something else. Because everything has a cost to it. And as Belinda just said, giving a treatment that doesn't do anything for a patient is the worst thing. In fact, none of us want to do that at all. So we don't like to guess in breast cancer at all. And trying to understand that if it is a few more days or even a few weeks to make the decision that is right for you, we are doing that you know, with a whole team. And that's what breast cancer is, you've seen tonight. It is a whole team. And that's going to be, I mean, the breast cancer is not going to change in those days or weeks. It is very difficult. And I'm not saying people walk out the door and feel a lot better, but, you know, that's hopefully what we can try and impart.
Well, I think I've heard again and again in these sessions that day one is the hardest day because it's the day on which you know the least and you fear the most. And it's a team effort, and I really want to thank all of you for being a great team here this evening and offering all of your wisdom and expertise and experience, and to all of the people who are watching and thinking about these questions, whether they're for themselves or for people that they love. I know that the time that you've committed this evening has been a light bulb moment or collection of light bulb moments for all sorts of people. So thank you very much on behalf of all of us on this call. Could I thank our panel, Belinda, John, Keelan, and Katrina. Thank you to everybody who's joined us and sent in questions, of course, today as well. I'll remind you this Q&A has been recorded and it'll be available on the Breast Cancer Trials website tomorrow, and you'll get an email link from the team which will allow you to rewind, rewatch, or share with anybody that you think might benefit from what we've talked about tonight. You know that Breast Cancer Trials is committed to improving outcomes for every person diagnosed with breast cancer through clinical trials research. Thank you for being a part of that this evening. I wish you all the best, and thanks for joining us. Goodbye.